Hi, my name is Teresa Rincon, and I'm one of the senior telehealth consultants at Cirrus Consulting. I'm going to provide you with a 15-minute lightning session, provider compliance, documentation, and workflow. The content of this presentation is informational only and should not be used as legal advice. The information provided is valid on date of presentation, but these laws and policies and regulations are changing and evolving quickly. The purpose of clinical documentation, what is that? And how does it differ in telehealth? The purpose of clinical documentation is to provide a clear, complete, reliable, accurate, timely, and legible communication about a patient's disease burden, the scope of services and interventions that are provided by the clinicians, a description of how those services were provided, and the patient's responses to the therapeutic interventions and services. For telehealth, clinicians should add who used the telehealth tools and how into the description of how and where those services were provided. So really what we need to do as clinicians is follow standard of care. What are our standard of care practices for documenting in the legal medical record? And then we add things in there to explain how those services were provided. What else should we talk about when we think about documentation? Well, when you're documenting for telehealth, you need to specify the modality. So examples of that would be that you used a two-way interactive video session, and you might name the platform that you used. Or patient wasn't able to connect to the two-way audio video session for some reason or the other, and so you switched to a telephone encounter. Or maybe you used just a telephone encounter for medication management, and consultation was performed that way. You might have also used asynchronous or store and forward type of information, like information back and forth on the portal or text messages, pictures, emails. You want to document the patient's physical location. Examples might be that the patient was in her home in Boston, Massachusetts. It's necessary for billing purposes and determining the venue in the event of regulatory or professional liability. Document the provider's location. Where are you sitting? Where are you located at the time that you're providing this service? Confirm and document the patient's identity. Many times for new patients, we'll have them hold up a photo ID, get it close to the camera so we can confirm that we are actually talking to the right patient. And we can document how we confirm that patient identification, and that should follow our normal operating procedures within our health system. Provider identification disclosure is also something important to do. It really is good practice, but in Massachusetts, it's actually required. So verbally or electronically disclosing the title, licensure, and if applicable, board and specialty certifications. What else can we say about documentation? Well, what about consents? Federal guidelines do not stipulate a separate consent for telehealth outside of the general consent for treatment, but federal guidelines do require for communication technology-based services. So those are defined as those types of services that are not equivalent to any in-person service, like remote patient monitoring. We don't usually do remote patient monitoring in the office. We do remote patient monitoring for patients at home. Peer-to-peer consultations and online visits might also fall under that category. Most states require some form of documented consent. It can be verbal, written, or electronic. Some states also specify other requirements, like Mississippi requires that clinicians discuss the risks and benefits of telehealth. Virginia requires a detailed list of baseline information to be obtained, and Massachusetts requires that telehealth consent process match the in-person process. Can you tell us more about documentation and disclosures? Many people ask about that. Already mentioned, some states require that providers disclose verbally, electronically their title, their licensure, and if applicable, board specialty. But really, that's just good practice, right? We should introduce ourselves to our patients. Here in Massachusetts, providers must do and document the following. They have to ask the patient for verbal consent after disclosure of any relevant privacy considerations or information that the patient may revoke their consent and end the visit at any time. Disclose how the patient can obtain the personal medical services in case of an emergency. So even if in the middle of the call, the patient starts, well, I'm having chest pain. Well, we've got to disclose to them things they need to do, like call 911, disclose their location, and verify the patient's location. Every state may have other nuances. For example, here in Massachusetts, an initial telehealth visit or the provider must review all relevant medical history and records prior to the visit. For follow-up telehealth services or for an existing patient, the provider needs to have access and review all available medical history and records during the visit. Documentation should include evidence that all appropriate consents were obtained and disclosures made, as mentioned before. And at the federal level, the Cures Act, which was effective in last year in April, requires appropriate access, exchange, and use of information. So we have to be able to share that information back and forth with our patients. What about other states? Great question. In Connecticut, the permanent statute requires this: a telehealth provider shall provide telehealth services to a patient and when the telehealth provider is communicating through real-time interactive two-way communication. So again, you have to look at your state statutes to figure out what is required and what is not required. The provider must have access to or knowledge of the patient's medical record, much like Massachusetts. Conform to the standard of care. Again, if we fall back on standard of care, we're probably going to be safe in most cases. And it is the professional and right thing to do for our patients. What about other states? Well, in Rhode Island, this is what they have on their GOV website, that they've documented patient evaluation, including history and physical, evaluated adequately to establish diagnosis, identify underlying conditions or contraindications to the treatment recommended and or provided, must obtain prior to providing treatment, including issuing prescriptions, electronic or otherwise. A lot of this sounds just like standard of care. Physical evaluation means using the tools and resources available through telemedicine and the internet, and to use those tools appropriately, and to understand that a physical evaluation done via telemedicine or the internet is inherently different in many times than a traditional in-person encounter. Although many of our devices are getting better and better at doing evaluations, such as stethoscopes, dermoscopes, otoscopes. We're getting to be pretty good at using these tools. What about other states? Well, Mississippi, there's a long list of best practice requirements for care providers using telehealth tools. So they have to verify that the person requesting the medical treatment is in fact who they claim to be. Well, we saw that in other states. Conduct an appropriate history and physical examination of the patient that meets, again, applicable standard of care. Establish a diagnosis through the use of accepted medical practices. I mean, much of this sounds like what we already know. Discuss with the patient the diagnosis, risks, and benefits of various treatment options and obtain informed consent. Ensure the availability of appropriate follow-up care and maintain a complete medical record. Sounds similar. Where can folks find information about federal and state level telehealth requirements? Well, the Center for Connected Health Policy is an excellent resource to find the information at both the federal and state level. The regional telehealth resource centers like the Northeast Telehealth Resource Center, the Mid-Atlantic Resource Center, those are great too. To find your region's telehealth resource center, you can go to telehealthresourcecenter.org. Blue Cirrus does these lightning sessions, but we also have lots of free webinars, and all of our previous webinars are stored and accessible at our bluecirrus.com Knowledge Tsunami page. So what about clinical workflows? What needs to change there to support telehealth? Well, let's define clinical workflows. A workflow is a series of physical cognitive tasks that are performed by various people within teams that can occur at several levels. It could be one person conducting tasks. It could be tasks between people, across teams and organizations. And those tasks within the workflows can occur sequentially or simultaneously. So let's talk about clinical workflow best practice. Well, anytime you make a change to practice, to any workflow, you're going to see potential fail points. What do I mean by that? Well, when you introduce telehealth tools, you need to examine where in the current workflow do those tools replace or change the steps and tasks that you would have done if it were an in-person visit. You will need to collect workflow information as early as possible. You want to do this before you implement. You can start by listing the steps that each team member does. So everyone on the team, what's their role? And then, hey, maybe list the steps of the patient so that you can see from the patient's standpoint, what are you asking them to do to connect to a telehealth visit? Consider and document what could go wrong. So each step, evaluate what could fail in this step. Could somebody forget the step? Could somebody not have the right technology? What could happen? Look for opportunities to reduce the number of steps as well, because every step, by the way, could turn into a fail point. And then call out and document any workarounds. So if the technology doesn't allow you to do something you would normally want or you would hope your technology could do, and you have to do what's called a workaround, you need to document that. You need to keep track of them. They're supposed to be temporary. This will help you to uncover potential fail points. Walk through the steps in the simulation. It's called simulation modeling, where you actually get in a room, a group of people, you role play all the various roles, and you walk through the steps you've documented. You do this before go live in order to uncover potential fail points. Continue to assess workflows post-implementation, because things can happen that you didn't predict. The Agency for Healthcare Research and Quality has an entire toolkit that can help you make sure you have an expert to help you assess, because trying to do this alone can be difficult at times. With the public health emergency ending, why does this even matter? Well, you're correct. Waivers and flexibilities at federal, state, and payer level have been extensive, but they have been tied to the duration of the PHE. And we know the federal PHE has been extended again and continue to go until July of 2022. But the reality is most of what I've shared with you today was in place prior to the PHE. Telehealth was here before the pandemic. The pandemic just forced the genie out of the bottle and showed the world that it can and should become another modality of care. I don't think there's any way to get that genie back in the bottle. If you have any questions for us, we'd love to hear from you. We hope you come back to one of our lightning sessions to learn more about telehealth, where it's evolving, where it's going, and what you might do to implement a successful program. Thank you.